Good evening, everybody. I welcome you all for today's session. Dr. Alpana Joshi, she is from Mumbai. At present, she is working as a radiologist at Shobha Diagnostic Center. She was a gold medalist in MD examination. She is practicing in Mumbai since last 30 years. There are so many publications on her name. Her areas of interest are obstetric and gynec sonography, fetal echocardiography, mammography, pelvic floor imaging, and pediatric sonography. I welcome Dr. Alpana Joshi on behalf of Garima OBGYN Society for today's session. The topic is estimation of gestational age and diagnosis of growth disorders.
Thank you. Thank you, sir. Should we start?
Yeah.
I will keep my video off during the presentation because of heavy rains in Mumbai. The internet connections are a little unstable. So once I start, I will put the video off. In case I'm not audible or if there is any break, do give me a call. We can just go back and then start again. So should I share my screen?
Yes, ma'am.
You have to enable me to.
Yes, yes.
Is it seen? My screen is seen there.
Hello.
Should I start?
Just a minute, madam.
Let me know when I can start. The screen is seen, right?
Yes, ma'am. It is visible.
Okay. Thank you, Dr. Rajesh, for inviting me for this session. Are you set?
Okay, ma'am.
Yeah, we can start. Am I audible now properly?
Yes, ma'am.
Okay. So I think the estimation of gestational age and assigning the correct, the expected date of delivery is actually the important part of the obstetric sonography. Whatever sonographies you do afterwards in pregnancy are futile unless that first dating scan is done properly. So I think this will be should I continue? Should I continue?
Yes, ma'am. Yes.
Okay. Accurate dating is vital for timing of appropriate ANC care, scheduling and interpretation of the different ANC tests. Something like dual marker, which is done only between 11 to 14 weeks, a quadruple marker, which is done between 15 to 21 weeks, and things like that. So this interpretation and scheduling of tests is also important, and it depends on the dating scan. Determining growth, it may be either less or more, and that is the most important part after that anomaly scan whenever we do the ultrasound. And of course, for intervention purpose, when to deliver, planning for early delivery, if should not be post-dated, or it should not be iatrogenic prematurity. So all these things will depend on your first dating scan. So which are the methods of determination? LMP, of course, but it's all query. A lot of educated women also sometimes don't remember the last menstrual period very well. The IVF is, of course, a very accurate dating from the date of embryo transfer. So it's plus minus 1 day at the most. If somebody who was doing ovulation studies or somebody who has done IUI, you know when that ovulation has occurred, but then again, it is not necessary that it will exactly correspond to that time. And it is plus minus 3 days, of course. In first trimester, we date the pregnancy according to CRL, and in second trimester by BPD, HCFL, AC, averaging it out, or the most accurate will be the head circumference. So that needs to be remembered. If the other parameters are coming quite different, the head circumference is the best parameter. So whenever a patient comes for a scan, this is even before you have started doing the scan. And this is the first page when you make the new patient. There is this LMP column. We feed in the LMP here, and then the machine gives you some gestational age and the expected date of delivery. So you do the ultrasound, you do the biometry, and then the machine gives you average ultrasound age, and machine again gives you one expected date of delivery. So in the report, in the final report from the machine, there are always two EDDs. We will see which one to take in our subsequent talk. So early pregnancy scans, most accurate for dating is the CRL. And after 14 weeks, BPD, HC, AC, FL, average of that, but the accurate one will be HC if these parameters are not corresponding to each other, if they are not matching with each other. So when the gestational age matches the ultrasound biometric age, we assign the EDD as per LMP. If the patient comes to me for the first time at 8 weeks of by the LMP, and I do a scan and I see that the CRL also corresponds to say 7 weeks, 6 days, then I will assign the EDD as per the LMP. Whenever the gestational age mismatches the ultrasound biometric age, we assign the EDD as per the ultrasound age. So what is the criteria for this mismatch? At what discrepancy we should reassign the due date? That is the crux of the issue. So there was a committee opinion, the ACOG, AIUM, the SMFM, all these three societies together, they came to a consensus report or a committee opinion. So that mismatch criteria will be by, first of all, the LMP gives you expected gestational age, and your ultrasound gives you the biometry, the ultrasound age. So then you should look for the mismatch between the two and reassign the EDD. So this committee opinion has divided the pregnancy according to less than 14 weeks and more than 14 weeks. Why have they divided it like this? Because in less than 14 week scans, we will look at the CRL, and more than 14 weeks, we will start looking at the HC or the averaging of the parameters. So less than 14 weeks. Now in less than 14 weeks, there are two subdivisions. Less than 9 weeks and between 9 weeks, 8 weeks, 6 days to around 13 weeks, 6 days. Measurement is done only by CRL. If the discrepancy is 5 days, then we reassign the EDD, 5 days or more. And if the pregnancy is between 8 weeks, 6 days to 13 weeks, 6 days, then the discrepancy of 7 days is acceptable. So anything which is 7 or more discrepancy, then we reassign the EDD. We will see these with the help of examples towards the after the chart is over. But you should remember less than 14 weeks and more than 14 weeks. Why this division? Because less than 14 weeks, we can take CRL as the accurate measurement. And beyond 14 weeks, we can't really take a CRL. So it goes to BPD, HCFL, AC, and most accurately for the HC. So when it is beyond 14 weeks, always remember when we are talking about 8 weeks, 6 days, 13 weeks, 6 days, it is by LMP. It is the gestational age. What comes by feeding in LMP? What comes by biometry is what you get on the ultrasound. That is the ultrasound average. Between 14 weeks to 16 weeks, you go by the averaging of this, and 7 days discrepancy is acceptable. Again, we will come to this point, averaging out things if it is really done or not. Between 16 weeks to 22 weeks, it is discrepancy of 10 days is acceptable. Always remember, if the patient has come to you at 17 weeks, you will always want to know if the ultrasound scan was done before or not. You will not reassign the pregnancy if there was one ultrasound report which was done before. Patient is not carrying it, but you will tell the patient to get that report, and only then you will start adjusting or readjusting the EDD. Many a times, if the sonography is done in early pregnancy in the hospital, the clinicians are doing it, the report is not dispatched the way the radiologist does. So what happens is they usually tend to write in on their case history sheet that this is 9 weeks pregnancy, 6 weeks pregnancy. So there has to be the EDD which is given in the machine, and that is the most important point. Many times when small thermal printout a report is given, so if there is a report page in that, we always make it a point, make efforts to look at that and then see if there is any mismatch. So whenever any scan is done in early pregnancy, it is not important just to write the CRL and the FHR. You have to always look at the discrepancy between these two findings. When it is between 22 weeks to 28 weeks, 14 days discrepancy is acceptable, but then it becomes too risky to readjust the EDDs at that time. So early pregnancy scan is that whatever is the dating scan, if the discrepancy is less than the variation expected, then assign the EDD as per LMP. Once assigned, don't change the EDD in subsequent reports. That is something which is important. If the discrepancy is more than the variation expected at that gestational age, then assign the EDD as per ultrasound. And again, once assigned, don't change the EDD in subsequent reports. Make the mother aware about the difference. Stress the importance of carrying previous reports for the subsequent scans. That is, I think, something which is very important. So let us see a few examples so that you understand this point a little better. Say, suppose this was the LMP and the EDD by LMP is 28/12/2020. Now, this is something which comes to you before you do the scan. Then the gestational age is 7 weeks, 5 days. So all these three things are something which is there in the first new patient report page, new patient page in the machine. Then you do the ultrasound and then you find that the CRL is corresponding to 7 weeks, 2 days. So how much is the discrepancy? 3 days. Pregnancy gestational age is how much? Less than 8 weeks, 6 days. So how much discrepancy is acceptable? 5 days discrepancy is acceptable. What is your discrepancy? 3 days. So there is no mismatch. And in your report, which EDD will be given? As per the LMP. And only one EDD will be given. We will not write EDD according to LMP is so and so, and EDD according to the biometry is so and so. This is not done. Only one patient is going to deliver only on one day. So then only that one delivery date is important. Now, similarly, if you see that the gestational age is supposed to be 7 weeks, 5 days, and CRL is corresponding to 6 weeks, 6 days. Now, how much is the discrepancy? 6 days. Below 9 weeks, that is less than 8 weeks, 6 days, the discrepancy of 5 days and plus 5 days and less is acceptable, and anything which is 5 days plus is not acceptable. So now you will have to reassign the EDD as per the ultrasound. And what is that? That is not 28/12, but it is 3rd of January 2021. So that has to be remembered. Now, if the patient came to you and you saw that the gestational age is 11 weeks, 6 days, again, there is this asterisk here. When the patient has come at 11 weeks, 6 days, always you ask her whether you've done the scan before. Anytime the patient comes to you, even if it is coming to you at 6 weeks, we always ask the patient, have you done the scan before? That is something which is very important. The staff is trained to ask the patient, is there a previous report? And you show it to me. That is the first question you ask the patient before the patient is even lying down on the table. So now the CRL corresponds to 11 weeks. Now the discrepancy is 6 days. What your chart says, if the pregnancy is between 8 weeks, 6 days to 13 weeks, 6 days, because it is supposed to be 11 weeks, 6 days. The method of measurement is CRL, of course, but 7 days discrepancy is acceptable. Now, how much is it? 6 days. 7 days and plus, then you reassign the EDD. 7 days and less, you assign it as per the LMP. So the EDD remains as what came in the machine by feeding the LMP. Now the patient came to you at 19 weeks, 4 days. Again, there is this asterisk here because conditions apply. This has to be the first scan, what you're doing. If there was a previous scan, even if it was done by a clinician in the hospital where there was no report kept, but you should go through the case history papers and try and see if there is a note made by the clinician about at what date it was done and how many weeks was she. So now you find that the biometry corresponds to 18 weeks, 1 day. Now, what will you do? Will you reassign the EDD or will you keep the EDD as per LMP? The discrepancy of 10 days is acceptable. Anything less than 10 days is acceptable. But here it is more than 10 days. Now, should I jump to the conclusion that these are wrong dates, that it is a delayed conception? No. What I should do is look at the parameters. The BPD and HC are 19 weeks. She's supposed to be 19 weeks, 4 days. And why there is that average ultrasound age has changed? Because AC and FL are actually lagging. So that's why the HC actually is a better parameter. If everything was 19 weeks, 1 day, 19 weeks, 2 days, 18 weeks, 6 days, it is okay. If everything was coming as 18 weeks, 1 day, 18 weeks, 0 days, 18 weeks and 17 weeks, 6 days, then that averaging out was okay, but not in this case. This may be about the FGR. This may be about some other syndromic condition. So you can't really reassign the EDD and you will have to go into detail and look at the other findings on ultrasound. So that's why that is important. The HC is supposed to be the better parameter. So whenever you start doing the scan, you first think is whether the dating scan is done and whether it is available. If it is not available, then this is your first scan. So what you look at the ultrasound age. Only if multiple parameters are similar, then you will go and readjust it. If it is not similar, then you will have to look at the other possibilities of growth disturbance, infection, chromosomal problems, skeletal discrepancy, and so on and so forth. So what then can be done? You should repeat the ultrasound after 3 to 4 weeks and look at the growth velocity. And only then reassign the EDD. Don't be in a hurry. If I do the scan for the first time at 19 to 20 weeks and I find a discrepancy, I will write in the report that there is a discrepancy, but the HC is corresponding. So we will look at the growth velocity after 3 to 4 weeks. I will also look at the uterine artery Doppler. I will see if the Leica is adequate. I will look for the other signs of infections. I will look for the other signs of chromosomal abnormalities and so on and so forth. We will not go into the details of that because we are talking about estimation of gestational age and not about those other things. So in the second trimester, this is what needs to be remembered, that if the parameters are similar, then average it out. But if they are quite different, then don't average it out. It may be that the head is small because of some problem. and the other parameters are normal. That's why you should always look at these parameters and then take a decision. If the patient comes to you for the first time in third trimester, unfortunately, you've missed the train. It is a wrong time to assign the age. So then, you will have to do away with whatever you've got. So these mistakes should be avoided. Giving different EDDs in subsequent scans according to ultrasound. Giving two EDDs in the report. EDD by LMP, EDD by USG should be avoided. Use only CRL to date the pregnancy in first trimester and not gestational age. Even in the city of Bombay, sometimes we see the reports where the gestational age corresponds to 8 weeks, the CRL corresponds to 7 weeks. So the machine takes the averaging it out and it makes it to 7 weeks, 4 days, which is not a correct way of doing it. Now look at this. The gestational age by LMP should be 8 weeks, 3 days. By the mean sac diameter, it is 8 CRL, it is 7. There is a discrepancy between the LM and the CRL of 1 week. But what is coming? It is coming as the average ultrasound age is coming as 8 weeks, 0 days. And the discrepancy is only 3 days. And that's why it was not reassigned. But then this is incorrect. Look at this difference. So then it will be a problem when you are doing the scans later on. So this mistake should be avoided. Use only CRL. Once you start seeing the CRL, don't take the mean sac diameter. Whenever you are doing a follow-up scan or a growth scan, always look at the previous report and not just one previous report. If the patient comes to you at 28 weeks, don't just look at the 20-week scan. Look at the first report. Just excuse me for a minute.
Really? Wanting, huh?
If there is a discrepant growth, look at the EDD given, see if it was reassigned. Enter the EDD in your machine and it will back calculate the estimated weeks of gestation. We will again see this with an example. So now, if this is your first page, the patient entry page, where you will write LMP and the machine will tell you the expected gestational age and the EDD. But if the EDD is different, which is there in her previous scan, so now if you see the previous scan, the corrected EDD is 3011 and not 1811. So now what I do is I don't enter the LMP. What I enter is the due date. So I write in established due date, this date. So while making the patient entry in the first page, I write this as the EDD. And then the machine tells me that she's supposed to be 21 weeks, 1 day and not 22 weeks, 6 days. So this is how you do it. And when we write the report, what we write is that single live intrauterine gestation, the 7 weeks, 6 days expected by LMP is 9 weeks, 2 days. This is the first scan. Remember, this is the first scan. So we say it is delayed conception. And then we write the assigned delivery date as 9/12/2020. And this is only one date which is given. You can write assigned delivery date by CRL or by ultrasound is so and so. So only one EDD is given in the report. So when she comes at 20 weeks for the next scan, now what am I going to write? I will write, instead of expected by LMP, I will write it as expected by dating scan 19 weeks, 6 days. And then the ultrasound biometry is 19 weeks, 3 days. And I will write it as assigned delivery date by dating scan is 9/12/2020. So that is something which needs to be remembered. So some of the softwares will have these corrected EDD and the backdated ones, so that can be done from the software or in the machine itself. In IVF conception, how do we do it? The embryo transfer date is known. Patients always remember the embryo transfer date. Now, some IVF centers do the transfer of embryos, which are 3 days old embryos, and some of them do it at 5 days old embryos. So you will have to do these corrections in the EDD accordingly. So what we have in our software, we write it as IVF embryo transfer date. And then depending on if it is 3 days or 5 days old embryo, we tick there. And then the software gives us one EDD. We enter that EDD in the machine, and the machine calculates, the ultrasound machine calculates the weeks of gestation for you. Now, what do we do in gestational age in twins? It is always the larger twin biometry is considered for dating. If by LMP it is 7 weeks 4 days, twin ACRL is 7 weeks 1 day, and twin BCRL is 6 weeks 5 days. Now there is a discrepancy between 7 weeks 4 days and 6 weeks 5 days. So should I reassign the EDD? No, because the larger twin is 7 weeks 1 day and the discrepancy is just 3 days. So I will not reassign it by ultrasound, but I will keep the EDD by LMP itself in the machine, in the report. So the points which you should remember are dating scan is best done between 6 to 10 weeks and by CRL, not by gestational sac. Assign the delivery date cautiously, and once assigned, don't change the EDD. Give only one EDD in the report. That is something which should be remembered. Don't give 2 different EDDs in the report. EDD by LMP, EDD by UHG should be avoided. So that should be remembered. Before you start doing follow-up scans, always look at the dating scan. Only then you will be able to correctly diagnose the growth disorders in your subsequent scans. Thank you.
No.
Should we go with the next one directly, or? Should I start with the next one?
Yes, ma'am.
I think somebody else's audio is also on. There is some disturbance at the background sometimes.
Yes, ma'am. Just ma'am.
So everybody can just put it off.
Okay, ma'am.
Yeah, it is seen, right?
Yes, ma'am.
So once we know the dating scan concept, it is very easy then to, pick up the growth disorders. Again, this is just a repetition of the previous talk. Accurate dating and assigning correct EDD in early pregnancy is important to determine the growth disorders later in pregnancy. So when gestational age matches ultrasound biometric age, we assign the EDD as per LMP. And when it does not match, then we assign the EDD as per ultrasound. And once assigned, we don't change the EDD in the subsequent reports. And this is what we saw in our previous talk. And this is just the summary of that slide. So whenever the patient comes to you for a growth scan, always look at the dating scan. Then you should know certain terms appropriate for gestational age, that is AGA. So the AGA fetus is the one whose size is within the normal range for its gestational age. So AGA fetuses typically have individual biometric parameters and or the expected fetal weight between 10th and 90th centile. So then those are average for gestational age. The small for gestational age fetus is whose size is below a predefined threshold for its gestational age. So their weight or AC is below 10th centile. Then we start calling it as small for gestational age. The large for gestational age fetus is somebody whose size is above the predefined threshold. So their weight or the AC is above 90th centile. Macrosomia is a term used when the weight is above a fixed cutoff, and that is 4,000 grams, or in some countries above 4.5 kg. So we don't call it macrosomia unless it is going beyond 4 kg. Then when it is say 95th centile, 3.8 kg, and the pregnancy is just 34 weeks, we will say that it is a large for gestational age fetus. So this is actually the chart which always is there in our ultrasound machine. This is the 10th centile and 90th centile. So all your parameters should always fall between these two lines. That is the crux of the whole lecture. So FGR or IUGR fetus is the one that has not achieved its growth potential. So there is a pathological smallness. So there is a difference between size versus growth. As long as you are maintaining a trajectory, it may be at a slower pace or it may be at a larger pace, but as long as you're maintaining that growth, it is good. Then the size doesn't matter. So that's why what is important is the growth velocity. It is important to plot the biometric graphs. Not single study, but all previous ultrasound biometry is to be plotted and compared if this feature is available in your machine, or there are softwares also which give you this facility. So this is just one reading. So you don't get a clearer picture by just that one reading. So see, look at this. Somebody who is growing at that 10th centile is still okay, as compared to somebody who was growing initially at a good speed, then it came to 10th centile, and then again was less than 10th centile. Or somebody who had a growth potential, it was growing at around, say, 80th centile at 28 weeks, then at somewhere at 31, 32 weeks, it came down to around 50th centile, and then at 35 weeks, it is just at around 12th centile. Now, the machine will not raise a red flag because it is not less than 10th centile. But look at this. This fetus had a potential to grow at that speed, at that trajectory, but it is now falling down. So this one is also FGR, though it is not less than 10th centile. So that needs to be remembered, and that's why the growth velocity is very important. So whenever you want to define this SGA versus FGR, the first step is to define smallness, correct? So smallness is defined by AC and or expected fetal weight less than 10th centile. Then that just raises a red alert. So there was again a consensus statement in 2016, which defined the early onset and late onset FGR. Then it decided which parameters are useful to detect FGR, and it described the solitary versus contributory parameters. So we will again come to each of this. Defined early or late onset. So what is early onset? If you detect the FGR before 32 weeks, it is early onset. And if it is after 32 weeks, it is late onset. Then which number at what gestational age you take this? It is not the ultrasound age, it is the gestational age. By your dating scan or by your LMP, whichever is accurate, if the fetus is supposed to be 31 weeks, 2 days, then you, and is small in size or FGR, you say that it is early onset FGR. If the patient has come to you at 34 weeks, according to her dating scan, she's supposed to be 34 weeks, and you do the ultrasound and you see that it is just 31 weeks. Then do you call it an early onset FGR? No. You start calling it as late onset FGR because she's supposed to be 34 weeks by her dating scan. So that is easy, simple. Now we come to which parameters are useful to detect the FGR. So which are the parameters? Biometry and Doppler, correct? In biometry, it is AC and EFW, the absolute values, and AC crossing centiles and EFW crossing centiles. We will come to this in the next slide. And there are Doppler parameters, which are umbilical artery Doppler, CPR, and uterine artery Doppler. The MCA Doppler, the DV Doppler, all these things are not there to diagnose FGR. They are there to prognosticate when to deliver. So we don't include it here. CPR, umbilical artery Doppler, and uterine artery Doppler is there to diagnose the FGR. Which are the abnormal Doppler parameters? When do you call them abnormal? When the umbilical artery PI is more than 95th centile, uterine artery PI more than 95th centile, or CPR less than 5th centile. Now, how do we take it? What is the physics behind it, or what is the pathophysiology behind it? And how is the Doppler done? All that we are not really going to include now. Once you get the report with some PI values, say 90th centile, 96th centile, or 50th centile, you should just know the interpretation of that. So abnormal Doppler parameters, again, these MCA, DV are important in decision-making about timing of delivery. So that will be, a separate kind of a discussion. Then we come to solitary versus contributory parameters. So solitary parameter is sufficient to diagnose FGR even if all other parameters are normal. And contributory parameters require another parameter to be present to diagnose the FGR. So we will just come to this. See, now you have detected the smallness at, say, 32 weeks. So it is early onset. By what parameter? Either AC or EFW less than 10th centile, correct? Now you see if it is less than 3rd centile, or you look at the Doppler if there is absent end diastolic flow, then it is directly FGR. Even if your all other parameters are okay, if this parameter or this parameter is present, the EFW or AC less than 3rd centile, or umbilical artery showing absent end diastolic flow, then you can straightway call it as FGR. So that is a solitary parameter to diagnose FGR. But if you see that the AC or EFW is, say, 6th centile, it is less than 10th centile, so it is a small fetus, but it is 6th centile, not less than 3rd centile. Now you will need a contributory parameters to diagnose FGR, correct? So what are those parameters? This less than 10th centile combined with umbilical artery PI or uterine artery PI more than 95th centile. So then you will start calling it as FGR. Otherwise, you will say it is small for gestational age. We will again see it with the examples in the next slides. Excuse me. So if the Doppler parameters are abnormal, you will say FGR. If the Doppler parameters are normal, you will still label it as the small for gestational age. So these are the International Delphi consensus criteria for the early onset FGR. So this is the solitary parameters. Less than 3rd centile or umbilical artery end diastolic, absent end diastolic flow, or this plus any one of these. The less than 10 centile criteria combined with either this or this. Understood? So now you come to the late onset FGR. Again, the smallness is detected because it is less than 10th centile, correct? So you again look at if it is less than third centile. If yes, it is FGR. Solitary parameter to diagnose FGR, correct? This is in late onset FGR. Now, if it comes to you in late onset FGR, where the ACEFW is less than 10th centile, and it is not less than third centile, between third to 10th centile. So you will need to take the help of contributory parameters. So what are those? 2 out of 3 of the following, either less than 10% or a crossing centile by 2 quartiles. This is what we saw. If somebody who was growing at the speed of 80 centile has dropped it down to 20 centile, if the weight is now 20th centile, it has dropped by 60 centiles, which is not a good sign, because 2 quartiles is 50. Quartile is 25. So 2 quartiles is 50%. So when it drops down by that, in late onset FGR, especially this is important, because many a times it may not really fall exactly less than 10 centile, and that is where the growth velocities are important. CPR less than 5th centile or umbilical artery more than 95th centile. This crossing centile 2 quartiles is slowly losing its importance. Maybe in the next few years, the Gratakos group, at least Barcelona group, is thinking of taking that out, but as of now, it stands. So if yes, FGR, if no, then small for gestational age. So again, this is the International Delphi consensus for late onset FGR. Less than third centile is FGR because it is absolutely small. It is severely small. And if it is between third and 10th centile, at least 2 out of 3, the criteria should be present to call it FGR. So let us take a few examples. If the gestational age by dating scan is 36 weeks, you did a scan, the AC is 6th centile, and the EFW is 8th centile. So obviously you have detected the smallness, correct? And it is a late onset smallness. Is it so small as to call it a excuse me for this small glitch here. If it is SGA or FGR, so that is what you need to decide. Is it severely small to call it directly FGR? No. So then you need to do a Doppler. So what does your Doppler say? PI is 1.5, which is more than 95th centile. CPR is 12th centile, it is okay. So now you have this criteria of the umbilical artery Doppler, which is abnormal. So you will call it as FGR. If you see this, again, the similar example, again, you have to decide whether it is SGA versus FGR. Is it severely small to directly say FGR? No. Then you have to look at the Doppler parameters. Now you see the AC is 6, EFW is 8, umbilical artery Doppler is 80th centile and CPR is 18th centile. Your Doppler parameters are normal. Your EFW AC is between 3rd to 10th centile. So you will call it as a small for gestational age and not FGR. Now you come to this another example, 34 weeks. AC is at 1.7 centile. EFW is at 6th centile. Umbilical artery Doppler is 80th centile. Doppler is normal. EFW is 6th centile. But look at the AC. It is at 1.7 centile. So it is directly FGR. You have to do a Doppler, of course, but even if the Doppler is normal, you will still call it as FGR because it is severely small. It is absolute criteria, solitary criteria to diagnose the FGR. So you should remember that all HGA fetuses are not FGR. All FGR fetuses may not be small, especially in the late 3rd trimester. So the growth velocity crossing centiles are important, especially in the late onset FGR. Correct interpretation of biometry and Doppler helps to differentiate FGR subset from the SGA fetuses. Thank you.